But yeah, no, I apologize for everything you guys had to go through. You gotta love Amazon Web Service crashing, that's affecting it. They are rebooting so they've got the East Coast online again, but they're working on now the central area. So hopefully it'll be back up for you all tomorrow. But we're gonna talk about ischemic heart disease. So we've talked about hypertension and how that can cause like microvascular damage and put you at a high risk of developing cardiovascular disease. We talked about atherosclerosis as leading as a complication of atherosclerosis being ischemic heart disease. So we actually now are going to start talking about ischemic heart disease. But let's start by doing just a couple of check on learnings from atherosclerosis before we move on. So the first one is, which of the following blood measurements is not a risk factor for future cardiovascular events? And this is from the textbook. So D. So I would delta is the correct answer. So elevated LDL cholesterol, I mean, that makes sense. That puts you at risk for cardiovascular disease. Elevated lipoprotein A, this is now something that's emerging science. We kind of talked about that on our FYI slide, where now lipoprotein A is now being actually used as a risk factor, where you may actually be more aggressive in managing their cholesterol, even if they have an overall low ASCVD risk. And then because atherosclerosis and the development of atherosclerosis is an inflammatory condition, folks tend to have mild elevations in their C-reactive protein. So all of those can lead to or be risk factors for cardiovascular events in the future. Okay, next one is a 66-year-old male sustained an anterior wall myocardial infarction 6 months ago. He's taking high-dose atorvastatin therapy, so 80 milligrams daily. A recent serum panel lipid panel shows that his LDL cholesterol is 110. What is the next appropriate step in lipid management? So this is kind of going back to our algorithm, but what do you think okay, correct. So basically this question's getting to, we put him on a maximally tolerated statin, his max dose atorvastatin. You don't add another statin to a statin, so that's not an option, right? So we're still not at goal. What can we do to get to goal? And the answer is, let's try ezetimibe or Zetia first and see if that works. If that doesn't, then that's when you can start to prescribe the PCSK9 inhibitors. So, yeah, so this is a question of recognizing that he's not at goal. What can we add to his therapy in order to get him to goal? Okay, so ischemic heart disease. Now, according to the CDC, you can see that the impact of coronary arterial disease is pretty significant. About $240 billion each year in the United States went to treating this disease. About one person in every 33 seconds in the United States will die from cardiovascular disease. That equates to about 700,000 people who will die annually from cardiovascular disease. Every year, about 805,000 people in the U.S. will have an MI, and of those, 605,000, it's their first one, but 200,000 of them, it's actually their second, their third, it's a repeat MI. So 200,000 people will have another heart attack even after they've been seen, they've been evaluated, they've started treatment for a heart attack. And then 80% of coronary arterial disease is preventable by living healthy. So we know there's a problem. It's a problem that we can fix, and yet it continues to be an issue for us. And I would argue is only growing in its issues in the United States because our obesity rates are going up, right? which means our hypertension rates are going up, our atherosclerosis rates are going up. Maybe our smoking rates are staying steady, but still way too high for what we should be doing. And we talked in our last lecture about kind of the risk factors of atherosclerosis, this kind of being the building blocks of ischemic heart disease. So what can we modify in our patient to put them at lower risk of developing ischemic heart disease, or even what we're going to talk about on Wednesday with the actual acute coronary syndrome. And then we talked about in our last lecture kind of the process on how atherosclerosis develops. And you can start to get this plaque that forms, which is basically just kind of this hardened structure that will then start to impede into the lumen of our arteries, which then will start to impede the normal flow of blood through that artery, okay? And what happens as that gets bigger? That starts to occlude the artery more and more. And that's what we're going to talk about today. So when that occlusion is less than 70% in the coronary arteries, you tend to be asymptomatic. You have no idea what's going on. You have no idea that it's developing. You're asymptomatic because of that plaque formation. But it's not until you get about 70% stenosis of the coronary artery that you start to have problems with exercise or stress. So conditions that get that heart rate going, I can no longer meet that demand with the supply, and now I start to have symptoms with exertion. So 70% stenosis is when you start to have symptoms with exertion. But that plaque continues to get worse, or you have an acute occlusion because a clot formed or something like that. But when you get to about 90% stenosis, that's when you start to have problems at rest. So you're just sitting there on your couch watching TV, whatever, then you start to have chest pain and shortness of breath and those types of things. But you can see your body can tolerate quite a bit before it starts to have problems. And there's this balance that the body has to maintain, where that supply equals the demand. And it's this dichotomy of the two to make sure that that balance is there. Granted, if I have to have an over of one, I would rather have more supply going than what I need, right? But if you have more and more supply, but you don't need it with that demand, then you're just wasting effort, you're wasting energy, circulating blood to an area that doesn't need it, where it could be circulating it to other vital organs that may need it. For instance, like the GI tract during digestion needs more blood supply going to it. But if you haven't just had a meal, why do I need to waste all that effort going to the GI tract if it's not adding any benefit or utility to it? So let's maintain that balance of supply and demand. But part of that is figuring out what is my demand and how am I going to supply that? Do I need an 18-wheeler to come in with its load to provide that demand, or can I just get a van and that's all I need? Of course, Amazon's probably not a bigger company today. So I promise this has been on for a bunch of semesters. So this was not put on based on today. But. So what factors go into that maintaining that supply? Let's look at each one of these factors individually. That scale slide had them all listed out. Well, let's talk about each one of these specifically so we can see how different disease processes could affect each aspect of the supply. So the first factor is, well, what's the oxygen content in my blood? This should be a steady state, right? It should be 98%, should be 99%, should be 100% in every one of you right here in this room, right? But let's say that they have a pulmonary disease they're COPDers or whatever, they're in some kind of respiratory failure, and now their oxygen content is only 80%. What kind of stress, what kind of limitations of getting that oxygen to the vital organs is going to be impacted with just that oxygen content and that blood being lower? So that's the first factor in supply. The next one is kind of a lot more complex, but it all comes down to what's the rate of coronary blood flow. So what is that blood actually getting into the coronary arteries? And remember that the coronary arteries are perfused during diastole. So what I'm looking at, my perfusion pressure, is my diastolic pressure. So do I have a diastolic pressure of 60 millimeters of mercury? Or am I in some kind of shock and now my diastolic pressure is only 20? Is that going to supply the coronary artery properly if my diastolic pressure is too low because I'm in shock? Okay. So that's 2A factor for things that could affect the rate of coronary blood flow. The next phase is, what's the coronary vascular resistance? So I have my pressure, but how willing is that artery going to be to take on that blood, that perfusion? If I have a narrow tube, then it's going to take a lot more effort to get blood circulating through that versus one that's wide open, right? So what can affect that, that factor? Well, first of all, it would be external compression, so contraction of the surrounding myocardium. So we talked about that's one of the advantages of the coronary artery perfusion being during diastole, because during systole, I have that myocardium clamping down, especially in the ventricles, right? It's clamping down, it's going to squeeze those arterial walls, and now that's going to disrupt flow going through because you're occluding that artery, right? So, so if I have it where that ventricle is not relaxing, that myocardium is not relaxing, then I can't get perfusion into those arteries. So that would be a factor in elevated heart rates, like an arrhythmia that has a heart rate of 180, 200 beats per minute. I'm decreasing that diastolic filling time, so that means I don't have as much time to perfuse those coronary arteries, because most of my time the ventricle is squeezed down, the myocardium is contracted, so I'm limiting the supply of oxygen and blood into the tissue. Then there's all these other factors that are there to kind of control that, that tone, that vessel tone locally. So you've got all these, you know, vasodilator factors and the vasoconstrictors. You have the neuro stuff, so what's the sympathetic nervous system doing? I'm in a high stress fight or flight kind of response, so now everything is upregulated. Or am I in a parasympathetic thing where I'm in rest and digest, and now I have a decreased tone to my coronary arteries. So, number of factors that affect the supply of blood and the supply of oxygen to the myocardium. But now let's talk about what factors go into affecting the actual demand of for the demand of oxygen and the demand of blood. You know, is it you have a couch potato who's just sitting there watching movies and eating, or do you have a triathlete who you know is towards the end of their you know, their marathon run? What is that oxygen demand at that point? And the factors that kind of go into this really are three main things. So you've got the ventricular wall stress, which it can be summarized with Laplace's law. I'm not going to ask you to calculate anything using this or remember this. If I have any engineers out there, it's just really there to kind of help you understand that wall stress. Second factor is the heart rate, and then the third factor is your contractility. But going back to the wall stress, one of the things to think about that could increase your demand is actually what is your preload. So we talked about how our preload, usually we have more stroke volume as that preload increases, right? But then we talked about, according to Frank Starling, that you get to a point where now, if you add more preload, you actually start to worsen that stroke volume, that cardiac output. And it kind of comes down to this. Myocardium tries to hold on to the myocardium next to it. And it's fine, but then as the pressure starts to increase, I'm having to work harder to maintain that pressure and that contact with the myocardium next to me. And that pressure increases. I'm now having to work harder to maintain that contact, which means with that increased work, I need increased oxygen. So that's how ventricular wall stress, as it increases, will increase that demand. Does that make sense? Heart rate, I mean, that makes sense. The faster you're beating, the more oxygenation you're going to need to just keep up with that oxygen need. Now, unfortunately, it also then affects the supply, which we already talked about, because that decreases your diastolic filling time the faster your heart rate is, right? So that can also impact the supply, but in a different way. And then contractility, the stronger I need the squeeze to be, the more energy that's going to be required, right? This is no different than you go to the gym, you try to lift a 1 pound dumbbell, right? How much energy are you exerting to lift that 1 pound weight? It's easy. But now let me give you a 100 pound weight. How much more effort are you having to use in order to lift that weight? And that's what's happening with the heart, with that squeeze, that strength of squeeze. The more you need, the higher the squeeze, the more oxygen is needed to meet that demand. And this list just kind of summarizes the different kinds of pathologies that we can see with cardiovascular disease that can lead to alterations in the supply and alterations in the demand. So atherosclerosis, that plaque narrowing we talked about, it limits the flow of oxygen and blood through. That endothelial dysfunction that causes a vasoconstriction or even a spasm, where now, instead of there being a plaque that's limiting that flow of blood, you're getting kind of an excessive constriction or spasm that prohibits that flow of blood through. And then volume depletion, so you have like dehydration, anemia, you just don't have enough boxcars to carry that oxygen. And then of course hypoxia, or the amount of oxygen actually in the blood. All of those things can affect supply. For demand, okay, tachycardia, especially if it's due to like an arrhythmia, it can cause that demand to go up. Hyperthyroidism, because that excessive thyroid hormone will cause an increase in rate and increase in strength of contractility, so that's going to increase that demand that's needed. Myocardial dilation, which when we start talking about dilated cardiomyopathy, or during our heart failure lectures with systolic heart failure, you're going to see that dilation, and that's going to add tension to the wall of the heart, and that's going to increase your demand. So that's supply and that's demand. What happens pathologically when now the demand is not met by the supply in the first place? And that's where we start to get ischemia, and that's where we start to get infarcts developing, where you get cell death developing because of that mismatch. And so what happens is you start to have that stress, and it shifts, the cells kind of shift from a aerobic metabolism to an anaerobic metabolism. Remember from biochemistry, which one produces more energy? Of course, the aerobic does, right? You get some energy production during anaerobic, but it's not nearly as much as it is if you provide oxygen to that system, right? Well, that's what's happening is now I've switched from an aerobic to an anaerobic, and now as part of that anaerobic metabolism, I start to produce free radicals. I start to produce other toxins that are not being cleared out because I don't really have the perfusion there to clear it out. So now those additional radicals and those toxins start to continue to cause further damage because they're just sitting there. And that's going to lead to disruption of the normal function of the cells. And when we're talking about the heart, we're talking about this myocardium, which the whole point of the myocardium is to have that coordinated squeeze to circulate blood, right? So we start to see that system, that pump starts to shut down, and that can lead to lots of additional consequences, especially consequences outside of the heart. It starts to affect all vital organs when that pump starts to shut down. Now, when we talk about ischemic heart disease, there's lots of definitions that get thrown out there. We're going to talk about each one of these over this lecture and next lecture. If you have problems kind of understanding what the definition of this term is, this is a great resource to just kind of look back at it, and it will let you know kind of what exactly is going on in this clinical setting. But the first definition I want to talk about is stunned myocardium. Okay, stunned, that means something like a temporary kind of thing, right? This doesn't sound like a permanent problem. Well, stunned myocardium occurs when you have acute but severe transient ischemia. So it's not just, hey, a quick second that the blood flow was affected and now the heart's fine, go back. No, there was an acute setting. It came on all of a sudden. It was severe enough to change that aerobic metabolism to anaerobic metabolism. But it was transient, so it didn't lead to permanent cell death. It just meant that the cells just didn't act normally. It affected their normal function. Those free radicals and those toxins kind of built up, and those are disrupting the normal function of the heart. But when that coronary blood flow is reestablished, now I switch back from anaerobic metabolism to aerobic metabolism, and then I got to start clearing out all of those toxins and free radicals out of the system so that those cells that were stunned can start to function again. Okay. So it takes a little time, but those cells will return to normal function. Does that make sense what stunned myocardium means? Compare that to hibernating myocardium, where now you have, instead of a transient blood flow, you have a persistent blood flow problem, where now it's not enough to kill the cells, so you're not having an infarction of those cells, but because they are not getting the bare minimum to function, they start to shut down. Okay? So these cells stop working. But they're still alive, so that means then if blood flow is returned to those cells, they will start functioning again. And when we do revascularization procedures, which we'll talk about, these are the cells that will start working again. So we're trying to identify these cells because I would expect that they're going to start working again and restore that ejection fraction or that function of that pump again, because I am addressing the problem with these cells and then correcting it and getting them functioning. Then you have another term called variant angina, or Prinzmetal angina is also known as. And this condition, although it acts like a STEMI, looks like a STEMI, smells like a STEMI, it's not a STEMI because there is no perfusion deficit from like a clot or anything like that. It's actually because of a spasm of the coronary arteries, and that leads to the development of this condition where it can really, that spasm could clamp down, almost entirely close and disrupt that blood flow through that artery. But once I stop that spasm, then blood flow returns through that. I don't have to do any procedures to restore that blood flow. Now, why does that spasm develop? Well, it could be from a number of different things. So it could be they have endothelial dysfunction, so like they smoked, and that caused some endothelial dysfunction, which causes that vasoconstriction, or that vasospasm. It could be cocaine related. Kind of the classic standardized test question is a cocaine addict comes in with chest pain, and they do a cath and it's clean, meaning there's no plaques. What was most likely going on? Well, it's variant angina or Prinzmetal, because that cocaine elicited that vasospasm of the coronary artery. And when I said it smells like a STEMI, looks like a STEMI, this is what I mean. So this is an EKG representation of a patient that comes in complaining of chest pain. As that pain develops, you start to see that ST segment starts to rise, now meets the criteria of a true ST elevation. It continues to rise, and it stays up there. It even gets worse. But then the pain resolves, and now that ST segment gets better and goes back down to normal. It doesn't show evidence of a infarct on it. So that's what you're going to see with variant angina, or again, Prinzmetal angina, where it's going to look like a STEMI. And you won't really know the difference until you go to the cath lab and they do the catheterization and they don't see that plaque limiting blood flow. Okay. It's the only way that you can diagnose somebody with Prinzmetal is by doing that imaging scan. Okay. So how do you treat this? Because you don't want these people coming in complaining of this chest pain and acting like they have a STEMI and bringing them back to get an angiogram or a catheterization every time they come in with this. So how can we treat it? Well, if they're coming in acutely, oftentimes it's just going to spontaneously resolve. So that may be that on the ambulance ride to you, it resolves. But if it comes to actually like trying to prevent these from happening again, calcium channel blockers are actually your first line therapies. Typically we think of the like amlodipine, like the peen ones as your primary, but even the diltiazem and the verapamil, calcium channel blockers, even those would work. Basically what happens is it blocks those that calcium channel so that you don't have these elevated levels of calcium necessarily in the smooth muscle cells of the artery, so you don't get that spasm, you don't get that contraction of the smooth muscle leading to this perfusion deficit. So that's how and why calcium channel blockers work well as first-line agents for the treatment of this. Now, when they come to you acutely, like they're in acute pain, they're complaining there's pain, you can give them sublingual nitro, and that will kind of overload that spasm or override that spasm, and then you get that vasodilation, and then the pain gets better and goes away. So, and then of course with managing for patients, if they smoke or they're doing cocaine, then we got to get them off those substances because that's what's setting them up for developing this condition in the first place. So that's Prinzmetal angina. Now, silent ischemia is going to be a lot more difficult to treat because these are folks who are having ischemia or even an infarct, but they have no idea because they're not presenting in the normal fashion with it. So it ends up being that their initial symptom or sign that something is going on could be a complication related to that ischemia or to that infarct, which could be like heart failure, it could be sudden cardiac arrest, it could be an arrhythmia of some sort. So there's all these complications that could present and be the presenting symptom of this condition. So kind of think of the people who are at risk of this are going to be like your diabetics who have like peripheral neuropathy already. Their sensory nerves are not working right to begin with, so they're not going to perceive that chest pain in the first place. Could be your elderly people. So they have so many other medical comorbidities. They're just not going to perceive that. They're on all these medications anyways for other things, that it's just going to kind of cover up the symptoms associated with it. And then women, unfortunately, also is a risk factor. So you may have heard women with heart attacks present differently than men with heart attacks, right? And there is truth to that. And it's because a lot of times they actually have the silent ischemia versus actually having what we're going to talk about with Levine's sign, where you're coming in with a stereotypical chest pain associated with a heart attack. If you have a patient you suspect may have this, okay, great, you can do an EKG or do some kind of workup or whatever with them. Maybe do an exercise treadmill test, put them under some kind of stress and see if there's a change. You may need to draw labs to look for evidence of cardiac enzyme leaks there. The chest pain or angina is not just an isolated event. There's actually a spectrum to this. And we're going to talk about just the left-hand side today, in today's lecture. And we're going to talk about all of these conditions in our lecture the next time we meet together. So this lecture just solely focuses on stable angina. One of the key things you'll see on this chart that highlights the importance of stable angina is you have a stable plaque. Okay? And these are people who typically have chest pain with exercise or with stress when they have at least a 70% occlusion of the coronary artery. But the way they present with stable angina is it's a pattern of chronic but predictable transient chest discomfort. So what does that mean? That means you have a patient who they can walk up one flight of stairs, no problem, no chest pain, nothing. But as soon as you try to put them up 2 flights of stairs, they start to have chest pain. You're like, well, that's kind of weird. Maybe it's a one-off. You do it again. 1 flight of stairs, they're fine. It's that second flight, all of a sudden, it starts to overtax the body, overtax the heart, and they start to have that chest pain. So it's that pattern of predictable behavior. A certain distance, they're fine if they remain under it, but as soon as they cross that threshold, they start to have symptoms related to it and causes them some difficulty. So what are the activities that could precipitate this exertion or precipitate these symptoms? So physical exertion, okay, that makes sense. Okay, increases your demand, that increases, it makes sense. Anger, so this increases your sympathetic nervous system tone, right? So anger, stress, other emotional excitement increases that demand where the supply cannot meet it, and you start to have symptoms. A large meal. So you're diverting blood flow to the intestines, and so that's going to take some of that volume that's going towards the heart. So now that myocardium is not getting the oxygen that it needs to meet that demand, and so you start to have problems. So think of this as like your patients coming in with the holidays and eating a large meal, and then they have chest pain. Cold weather, because of the stress, the vasoconstriction that occurs because of that cold exposure, Not that it gets that cold here in San Antonio, but we are getting ready to go into colder weather, right? Peripheral vasoconstriction, but generally, these symptoms only last a few minutes, especially if they stop the activity that triggered it in the first place. These also respond to nitro or nitrates pretty well because I'm going to cause that vein to dilate or that artery to dilate, get that vasodilatory effect, and now I'm restoring that supply to try to meet that demand, or I'm decreasing that demand by resting. And you can kind of see it in this picture that was painted, I think, by Netter, Dr. Netter, where you have an old man who went to a restaurant and had a big meal. He had to climb up a couple of flights of stairs. It's cold out, and so he's got a jacket on. And oh, by the way, he's also exerting some additional stress because he was carrying a load. And then he presents with chest pain, with clutching his chest, fist over the sternum. And this is what's known as Levine's sign. The only thing I'm going to add to it is let's put a cigarette in his mouth, and that will further put him at risk of having this event occur in the first place, right? So this picture summarizes what risk factors there are to trigger that stable angina to come on and have those symptoms. So now, one of the things you may be asking yourself is, we talk about chest pain, what does that really mean? Because if any of you have ever worked in a clinic before, especially like an active duty clinic, how many chest pain type of patients have you seen that end up not being heart related, right? A lot, right? I had coughed and now my chest hurts. Or I'm anxious and my chest hurts. I take a deep breath in and my chest hurts. There's so many things that go into chest pain. How can you, by your history, separate the non-cardiac etiologies versus the cardiac ones? And the difference is the chest pain that is described with cardiac is not like a sharp stabbing pain. It's kind of a pressure sensation. I feel like an elephant sitting on my chest. I have a lump in my throat. It feels like I'm getting squeezed, something squeezing my chest. Those are kind of the pain, the chest pain descriptors that you're going to find on your history that would make you more suspicious that this is a cardiac form of chest pain versus a non-cardiac form of chest pain. Okay. So just be careful of what the chest pain really, truly means. Now, there is a term out there called anginal equivalence. Now, these are symptoms that may be present in line with having that pressure sensation or that tightness sensation. But these are also symptoms where if you encounter these in isolation without that chest pain, consider this being a heart attack. So anginal equivalent. So unexplained tachycardia. Diaphoresis, like they're just sitting there and all of a sudden they start sweating like crazy. Not normal, right? They start to feel nauseated. And it's because the body is perceiving, and the reason that these anginal equivalents develop, the body is perceiving that stress there, although you're not experiencing the symptoms of it. It triggers the sympathetic nervous system to go into overdrive, and now you're just starting to display symptoms that are associated with that sympathetic nervous system. Okay, so so if you encounter any of these in your patients, especially like your elderly female patients who we talk about are at risk of silent ischemia, if you start to experience any of these things, think of this as they're having a heart attack until proven otherwise. But what is our differential if it isn't cardiac related, or it's not a myocardial infarction? Okay, what other things could it be? Well, pericarditis. We talked about how pericarditis in block 1 is like that positional chest pain, right? So worse with laying back, coughing, deep breath. but improves with sitting up, especially leaning forward. The GI tract. So the esophagus goes right behind the heart, right? So what is going on, like gastroesophageal reflux disease, that's triggering that pain sensation? I can tell you, I've seen esophageal spasm before in a patient, and that patient looked like they were having a heart attack until we gave them a GI cocktail that stopped the spasm of the esophagus, and then the pain went completely away. There is also the musculoskeletal symptoms, so costochondritis. So you have an inflammation of the cartilage between the ribs, and every time they take a deep breath in, you're just kind of putting tension and pulling that cartilage, and that's going to elicit that pain, right? So there are lots of other conditions that can cause chest pain. So what do you do when you have a patient who you're like, it doesn't sound like it, but I'm just not sure? What's my workup got to be here in the emergency room? Well, first of all, get some imaging. So get a chest x-ray, rule out some things. Let's get that EKG. Let's see if there's any kind of changes on my EKG, which even with stable angina, it can be completely normal. So they look like they're having a heart attack, or they look like they're having that stable anginal symptoms, but their EKG doesn't show any changes. That is normal, or can be normal for that. But you may have some non-specific kind of ST changes that can happen due to this stable angina as well. So you might get like the ST depressions, you may get some T-wave flattening or inversions. Rarely you could have ST elevations, only when they're having pain. Kind of think of it as like that Prince metal angina presentation. You're going to need to get some labs, so you're going to need to get troponins to check and see if there's evidence of cell death from ischemia occurring to the heart. Now, some of you may be wondering, you may have seen the term cardiac enzymes before, and you may have heard just troponins when we're checking for heart attack. Really, the cardiac enzymes panel has been kind of replaced by just troponins. But you can see when we ordered a cardiac enzyme panel, these were the values that we would get with it. So we would get myoglobin, which you can see causes an acute rise and then it quickly drops. We used to get CKMB, and you can see it's kind of a slow rise, but then it didn't really last long and it dropped off, right? So troponins now are the primary test that we order to test for a heart attack. And you can see it's pretty quick to rise, but then it lingers longer than the other values. So in the patient who's coming, like your elderly patients who are in the nursing home that only gets checked up on once a week kind of thing, you can check their blood to see if their troponins still are elevated, which at least would give you an idea that there is some kind of ischemia, stress, infarct going on to the myocardium. If you have a low-risk patient that you just still aren't quite sure if they have something or not, go ahead and you can just kind of observe them and just watch them closely to see if it gets worse. If you have an intermediate risk, then do a stress test of some sort. So do maybe exercise treadmill stress test or something like that. But if you have a high-risk patient, then just go straight to doing a reperfusion, revascularization procedure, which we'll talk about our options here at the end of the lecture. Right? But knowing what your risk factors are for your patients is important because it's going to affect what is the proper protocol and working them up to try to help you diagnose this or to manage this patient. Because there is an extensive treatment plan for these patients, and I'm just going to do this slide and then we'll go on our 10-minute break. But if you have a patient who's coming to you in the emergency room and they're having active chest pain, first thing you want to do is, of course, make them stop doing whatever the activity was that triggered it. So if they were walking around, well then just put them on the bed and just let them rest and drop that demeanor. Let's give them nitrates. So sublingual or the spray is preferred. Don't put the topical nitro on. We'll talk about in a couple of slides when you would do a topical nitro. But in the acute setting, you don't want to do a topical nitro. You want to do the sublingual. It's faster acting and easier to administer in the emergent urgent setting. And then I've got to come up with, how am I going to treat and manage these patients so they don't keep coming back to the clinic or keep coming back to the emergency room because they're having symptoms every time they try and go up to the second floor of their home. Right? So we'll talk about the chronic management when we get back from break. So I'll see you all in 10 minutes. Okay, so we talked about how do you manage your stable anginal patients in the acute setting where they're coming to you in pain. Now let's talk about how do we manage these patients, because this is potentially where they're going to come and see you in the primary care clinic. They're going to want to get managed for their stable angina, right? So when you talk about the actual treatments for stable angina from a chronic standpoint, our three goals really are, let's decrease the frequency of anginal attacks, okay? So let's decrease the number of times that they're having to go to the emergency room with chest pain, okay? The second thing that we're going to do is let's prevent the progression of this disease from stable angina to acute coronary syndrome, where they're actually having a bona fide heart attack, right? Leading to cell death and all the complications associated with that, right? So what can we do to prevent that from happening? And then, of course, anytime that we do a treatment, we should be asking ourselves, what is the advantage in prolonging survival or quality of life of this? So if you have a patient who has stable angina, who can't walk up the stairs to get to their bedroom, what kind of quality of life do they have? They can't walk up the stairs to get to their bathroom. What's the quality of life that they have? What can we do to help them so that they can get those bare minimum things done to take care of themselves and their condition and their family and all that kind of stuff? So how do we do that? Well, similar to atherosclerosis and hypertension, we got to address the lifestyle choices that are there. We know about all these modifiable risk factors that lead to atherosclerosis, lead to hypertension, lead to endothelial dysfunction that leads to that occlusion. So what can we do to decrease the risk of this happening and also the progression to more severe disease? So let's make sure that they're active. Being sedentary is never the prescription for health, right? We have to be active human beings in order to be healthy. Let's manage their hypertension. Let's stop smoking or stop all tobacco. Let's manage their cholesterol so they're not having further plaque formation. And also we'll talk about when we talk about statin therapy, but statins actually stabilize plaques that are there, so they stabilize those atherosclerotic plaques so that it doesn't progress to acute coronary syndrome. Let's control our weight, let's control our sugars, manage our diabetes better so that we're not adding all those additional stressors to the cardiovascular system. But when we go back to talking about how to manage these patients, I want to talk about like the three things that we're doing. So prevention for recurrent anginal attacks. So having that stable anginal symptoms, how can we manage those? Well, it's going to be a combination of beta blockers, plus or minus calcium channel blockers, organic nitrates, and ranolazine. And basically, this group of medications decreases myocardial demand and increases the perfusion. So you're getting more blood flow to the area with this regimen, and you are decreasing the overall demand that's required. So you're kind of addressing both sides of the supply-demand mismatch that occurs when you have stable angina. Now, the vasculoprotective medication regimen, this is there to prevent the progression of this disease from stable angina to acute coronary syndrome. So how can we prevent that acute development of a much more severe disease? Well, one, antiplatelet therapy of some sort, whether it be aspirin or clopidogrel, and basically you're preventing the acute formation of a blood clot that could occlude that coronary artery and lead to cell death. Let's lower the lipids, which will reduce the progression of plaques, and it will also stabilize the plaques that are there, so that it doesn't, 70% occlusion doesn't then progress to 75, 80, 90%, 95%, and that progression of that disease. And then ACE inhibitors is another one because we'll talk actually about those in particular, and why that's part of this regimen. So let's go back to preventing acute episodes and delve into each one of these medications specifically and how and why it works the way it does in protecting and addressing that first step. So beta blockers was our first line. Beta blockers from a cardiovascular health is always going to be your first line, as long as there's not a contraindication to prescribing it to your patients, because it's the only drug that's proven on countless studies to actually show not only a decrease in the risk of recurrence of ischemia and infarction, but it actually has been shown to have an increased survival rate. So there's an increased survival rate with beta blockers. And when you put a patient on a beta blocker, you want to titrate the dose so that the heart rate at rest is between 55 and 60, okay? So that's how you're going to titrate. So if they're coming in and it's like still 70, I can go up on that dose a little bit because my goal is 55 to 60 at rest. So what are we going to use? Well, kind of the main ones that we use are going to be like your metoprolol. That's a selective beta-1. Now there are beta blockers with alpha and non-selective beta blockade, so like cardiolol. I've seen that one used quite a bit as well in patients like this. So we said that for the proper patient, properly selected patient, beta blockers are first line. But what would make somebody not a candidate for beta blocker therapy? And the first thing is, well, if my goal is to get their heart rate to 55 or no less than 55, but their heart rate's already less than 55, there's no advantage by lowering their heart rate, right? If I'm going to throw a beta blocker on somebody who already has a resting heart rate of 50, now I'm going to drop that resting heart rate even more with the medication, and now it's 40, but now, sure, they're not able to stand because they get lightheaded and dizzy and nearly fall. If they have PR prolongation, so like in second or third degree heart blocks, then that's a contraindication because that's just going to perpetuate that heart block even longer. Heart failure, but only in a decompensated state. So we're going to talk about that in our next block, what it means to be decompensated. But beta blockers are contraindicated in that treatment protocol. If they have severe asthma, so those are like our absolute contraindications. Now, a relative contraindication would be our diabetics. And the reason for it in diabetics is the beta blocker can mask the symptoms of hypoglycemia. So now, instead of catching that their sugars are too low because they did too big of a dose of insulin and they're not going to provide that therapy to raise their sugars, instead of catching it at 50, now I'm catching it at like 20 or 30 when they're passed out. Right? So caution in your diabetics, especially like insulin diabetics, who may not be the greatest at managing their sugars because it can mask those hypoglycemic episodes. Calcium channel blockers, typically, these are second line because they don't provide any kind of mortality benefit. Okay, so studies have been done that show that calcium channel blockers do not provide mortality benefit. We would only use calcium channel blockers in patients where either they can't be on a beta blocker, because there's a contraindication to beta blocker, it's better to have this on board then, or the beta blocker isn't getting the heart rate to goal. So your max dose on your beta blocker, and they still have a resting heart rate of 70. Okay, then go ahead and add the calcium channel blocker with caution. But typically what we're thinking of when we do put calcium channel blockers on board in this situation is we're normally thinking about your non-dihydropyridines, so like your DILT and your verapamil, because I want to decrease that heart rate. Okay, nitrates. Now, this is your long-acting nitrates. This is not your sublingual nitrates, okay? Sublingual nitrates, fast on, but also fast off. This is going to be things like your transdermal or nitroderm formulations of nitro that you're going to give to your patients, because it's slowly going to leak in through the skin, and it's going to have a much longer duration of effect. So this is not your spray under the tongue, out of your system in 2 minutes kind of thing. This is going to be in your system for hours. Okay, so do your long-acting nitrates to do your chronic episode management. And then our last agent for the prevention of acute episodes is ranolazine, or the Ranexa, which is a sodium channel blocker. And it's been found in studies to decrease the frequency of anginal episodes and improve their exercise capacity. So, going back to our stairs, trying to get up to their second floor in order to go to their bedroom or to the bathroom, the hopes of putting this patient on this is that they can get up, they can climb that set of stairs to get to the second floor, so that they can take care of themselves and do what they need to. So. And this is just kind of a chart of the mechanisms of action and what we would expect to happen by putting them on each one of these medications, and an idea of what potential side effects are there for each of these meds. So, and then a non-pharmacologic aspect of the treatment that we need to talk about, though, is you've got to counsel your patients about a number of different things. We're throwing a lot of medications at them, right? So you got to counsel them about making sure that they take their medications. So that compliance is going to be an issue, because if they stop taking their beta blocker and now their heart rate's back up into like the 90s at rest, imagine that stress and strain that's going to happen on the cardiovascular system if you just have a much faster heart rate all the time, even when you're sleeping. They've got to do the lifestyle stuff to control the risk factors. So they've got to manage their blood pressure, they need to eat healthier, they need to exercise, they need to do all of those things in order to manage those risk factors. And then they should make sure that they're taking care of all the other health kind of recommendations. So vaccinations, flu vaccine is important in these patients, because if the patient gets flu, what happens? They get a fever, right? What's a fever going to do to your heart rate? It's going to increase your heart rate, which then means you're increasing your demand, and I'm already having a supply-demand mismatch, right? So I try to reduce the risk of other diseases impacting this chronic disease. So something as simple as getting vaccines can help reduce the risk of this cardiovascular disease. Okay. Questions about that regimen? Okay. Now let's talk about how do we prevent this disease from progressing from stable angina, so that pattern of predictable chest pain, to acute coronary syndromes, so that acute occlusion, where you have at least a 90% occlusion of the coronary artery. Well, let's do an antiplatelet therapy, so aspirin or Plavix, and that's going to prevent or decrease the chance and risk of a clot forming that will then cause an acute occlusion of the coronary artery. So let's put them on antiplatelet. Let's put them on that lipid-lowering agent. It stabilizes the plaques, and then it also will prevent the progression of that plaque from being a 75% stenosis to 90+%. So let's put them on that high-intensity statin and limit that. Let's put them on diabetes glucose-lowering agents. So this is going to be for your diabetics. Studies that have been coming out have actually shown that GLP-1s and your SGLT2 inhibitors actually have not only a decrease in cardiovascular benefit, but actually have a mortality benefit associated with them from a cardiovascular standpoint. So GLP-1s and SGLT2s are definitely go-to in managing your diabetic patients who happen to have stable angina. So this would be, if they're on metformin and they're okay with metformin, maybe we should be considering adding one of these agents or replacing metformin with one of these agents to manage their sugars better. And then ACE inhibitors was the last one, and this works by not only reducing your afterload because it's managing that blood pressure, but it actually shows with studies that there is some positive benefit in reducing scar formation and other kinds of compensatory changes that occur in cardiovascular disease that we're going to talk more about in later lectures. But ACE inhibitors have been shown, and they do carry a mortality benefit to them as well. So there is clear evidence that these patients should be on some form of an ACE inhibitor. But medications are not all we have at our disposal to manage these patients. So if you have a patient who is high risk, or you have a patient who is on all these medications and they're still having those stable anginal symptoms with the same kind of level of exertion, then we have our revascularization procedures to help manage these patients. And it really comes down to, there's two main types of revascularization procedures. So there's the percutaneous coronary intervention, PCI, you're going to hear that a lot. And then there's the CABG, or the coronary artery bypass graft surgery. And you can imagine, there is some difficulty in figuring out, like, when is one better than the other, and that's a topic of discussion in and of itself. But those are our two main revascularization procedures that we have. And basically what you're doing is you're restoring blood flow to the myocardium with them. And there's a different approach depending on which one you use on how you do that. And we talked about the three indications of doing revascularization procedures. So let's talk about percutaneous coronary intervention. Okay. So what exactly does that mean? Well, kind of think of it as a more or a less invasive type of procedure, where instead of going into an operating room, I'm going to go into the catheterization suite, like you see here, to do this procedure. Okay, it's still a sterile technique. There still is risk associated with this, but this is very different because we'll talk about this from a CABG standpoint, but I don't have to put the patient on cardiopulmonary bypass. So I'm not having to put in all these tubes to try to get blood circulating, oxygenated, and everything like that. So when I do a PCI, I am going to go in and I'm going to inject dye to find where this perfusion defect is occurring. So where is this plaque that's limiting the blood flow in that coronary artery? And to do that, I have to thread these wires up through an artery into the left side of the heart, well, just before the left side of the heart, there at the cusp of the aortic valve, and I'm going to inject that contrast dye into the coronary arteries to map it out and identify that lesion. If I identify a lesion, then I'm going to do an intervention to fix that problem, right? And the great thing is, the vast majority of patients who we do a PCI on, and we have to do some kind of intervention on them, 95% of them will have success. So by doing that intervention, that perfusion is corrected and they feel much better. But there are complications where either that vessel can then re-occlude or a blood clot forms and blocks the blood flow through it. So how can I manage these complications? Well, the stents tend to be the best thing to do this. So these are like these cage-like structures that you'll deploy into the artery. And we used to do bare metal stents a lot because that was all we had at our disposal. And basically, it's I deploy this cage, I inflate it, it restores that blood flow. But the problem is I now have bare metal exposed to blood. So what's going to happen is now that bare metal could be a surface that triggers a blood clot to form. Now the other thing that can happen is the body's going to recognize that this is a foreign substance, this is a foreign body that shouldn't be there. Let me do what's needed to protect myself from this thing, and let me wall it off. Well, the problem is that can then occlude that lumen that you just opened, and now you have the problem again. So to kind of deal with that last problem, the restenosis with the neo-intimal proliferation of smooth muscle cells, is they came up with a drug-eluting stent, which has a chemotherapy kind of agent on it, and it prevents that scar formation or that walling off of the metal stent. And so now it keeps that vessel open for a longer period of time, which is great because they're not having to go in for a repeat procedure because that scar tissue doesn't form. But the problem is because that scar tissue doesn't form like it should because of that chemotherapy agent preventing that growth, now that bare metal is exposed to the bloodstream longer, which sets them up for blood clots forming on it, which means these people are at a higher risk of having blood clots form, and we deal that complication with putting on a double antiplatelet therapy for a long period of time, so 6 to 12 months, usually closer to 12 months. So they're going to be on an aspirin, and they're going to be on a clopidogrel for at least 12 months. Now, after 12 months is done, then you can probably drop the clopidogrel and just keep them on a baby aspirin, and that's fine. But they need that double antiplatelet therapy for a longer duration. And here's just kind of an idea of what we're talking about. So we thread the catheter in, we gain access to the coronary artery. We inject dye. We identified this little plaque here. I can then put a balloon in there to kind of open it up, push all that plaque away. And then, or I can also then do a stent, which is this cage-like structure that's surrounding a balloon. I thread it in there, find where that occlusion is, and then I inflate that balloon, which then deploys that stent like you see here. And then it gets kind of embedded into the wall of the artery or in the wall of that plaque to address that perfusion deficit. And then this is just an example of checking to see, like, is a drug-eluting stent better than a bare metal stent in keeping that coronary artery open? And this is just an example of somebody who underwent a cardiac catheterization, immediate, as they were having symptoms. You can see this narrowing right here, so that's that perfusion deficit. We deployed that stent, and you can see it's now wide and open. It's great blood flow kind of going through it. At 4 months, I repeated the procedure, and you can see that that lumen is still open. There's no perfusion deficit. And then at 12 months, you bring them in and you do it again. You can see that they still have a good perfusion. Blood's getting through that stent, no problems. And that's the advantage of a drug-eluting stent compared to just the bare metal stent. Okay. Now let's talk about the cabbage, so the coronary artery bypass graft. Much more invasive procedure, higher morbidity rate, higher mortality rate, a lot more complicated. It's done in the operating room. I have to put them on a cardiopulmonary bypass machine, so you can see all these tubes coming in and everything like this on this picture. So this is not our go-to procedure anymore because it is a lot more invasive. There's a lot more of a recovery period for this. So if we can get away with a more minimally invasive where they're being discharged the next day from the hospital with minimal to no pain, let's do that procedure instead. So who would we do a cabbage for? We still have it as a tool in our toolbox. Who is the proper patient to get this type of procedure done? So typically, somebody who, when they did like the angiography, they found that they had at least 3 vessels that were affected. So instead of putting stents across all of these vessels, let's just go ahead and do the big thing, the big procedure, and fix the problem. If you have a patient who's diabetic, maybe you should be thinking about this one, and that's because these folks are at high risk of having extensive disease. If the LAD is the problem, then maybe this should be your procedure of choice, so that you're not having the widowmaker artery becoming occluded and causing an acute obstruction. Now, we said that this is a bypass graft. So where do we get these grafts? We don't actually use synthetic material like we're going to talk about with like the peripheral arterial diseases. We don't use synthetic material in order to fix this. Usually what we're doing is either doing a venous graft where we harvest the saphenous vein from one of the legs, and then we'll flip it so that the valves aren't a problem, and then you just attach it above the problem and below the problem, and then it restores the blood flow kind of around it. If you are a cardiothoracic PA, I have seen the PAs do this in the operating room. They harvest that saphenous vein all by themselves because while they're doing this part of the procedure, the cardiothoracic surgeon is putting the patient on a cardiopulmonary bypass. So you decrease, by having this happen simultaneously, you're decreasing the amount of time that the patient is on bypass, which means you have better outcomes. So, if anybody's interested in doing cardiothoracic surgery, this is something that you could do, participate on. The other graft that you can get is because there is an increased risk of atherosclerotic plaque formation because now you have a vein that's being exposed to pressures that maybe are a little higher than normal for it, is to do an arterial graft where I'm going to take the left internal mammary artery, I'm going to cut one end of it, and then I'm going to reattach it to kind of get around that obstruction. And this is much better at resisting atherosclerotic plaque formation because you're not having necessarily that same shear stress reaction occurring to it like you would with the vein graft. And this is just a kind of an example of what these two grafts would look like. So here's my internal mammary. I come down and then I bring it down and plug it into where that diseased vessel is. So we'll say that the diseased vessel is right here, so you're losing all of this perfusion here. So I'm just going to restore it past that obstruction, and now I'm restoring that blood flow. This is an example of the saphenous vein graft where I plug it into an area above, like in a vessel above where that perfusion deficit is, that obstruction is, and then I attach it below, and now I've kind of bridged around that obstruction. And then this is just risks and benefits of doing either one, but yeah. So you may be wondering and asking yourself, well, PCI is so great, you get a greater than 95% success rate in doing this procedure. Why don't we just treat and manage all of our patients with stable angina with a PCI instead of medications that potentially carry their own side effects and blah, 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 right? Well, the answer actually came down to this study here that was done initially in 2007, but then it was updated in 2015, which actually showed in the majority of your patients, there is no outcome benefit when you compare medication management to PCI. So there is no outcome benefits between the two. So that being said, most of your patients will do just as well with medication management as they would if they went straight to PCI. So try to manage your patients with medications first. If that's not adequate, that's not working, then you can escalate care to PCI. But try to keep them on medications. Yeah. Questions about this? All right, I will see you all.